This interim meeting of the NCOIL Health Insurance and Long-Term Care Issues Committee is now called to order. Hope everyone's having a great Friday. Ms. Ann Kennedy, would you please call the roll?
You know what, Mr. Chairman, it looks like we've got about 30 people on. I've got 11:59 Eastern. If you want to just give it one more minute, because I know we had close to 100 people register.
Okay.
So maybe just one more minute if you don't mind.
Absolutely.
Okay, great.
I'm on my end just trying to make sure I got all my technology quirks out of the way, hoping everybody can hear me or see me. Not sure you want to see me, but at least hear me.
It's good. We triple check the technology. Well, we are good to go.
Okay, awesome.
All right, Mr. Chair, I think we're good to go now. Almost 50, and I'm sure some folks will still start to roll in.
Okay. Thank you, Will. So just call to order this interim meeting of the NCOIL Health Insurance and Long-Term Care Issues Committee meeting. And Miss Ann, are you there?
I am right here.
Great. Always good to see you. Would you please call the roll?
I'm happy to. First, we have committee members, Arkansas Senator Justin Boyd and co-chair. Illinois Representative Rita Mayfield. Kansas Representative Bill Sutton. Louisiana Representative Hillman Frazier.
Present. Mississippi.
Mississippi? Oh, sorry. Michigan Representative Brenda Carter. Michigan Representative Brooke Hartsuff. Michigan Representative Mike McFall.
Hello, here.
Here, great. Montana Representative Nellie Nickel. New York Assemblyman Jarrett Gandolfo.
Present.
New York Senator Pam Helming.
Here.
New York Assemblywoman Pamela Hunter.
Hello, everybody, and happy Friday. We're going to let everybody in to the call and then we'll get started.
Right. And New York Assemblyman David Weprin. Ohio Representative Meredith Craig. West Virginia Delegate Walter Hall.
Here.
Okay, and now for other legislators who are not members of the committee, Arizona Representative Lauren Hendricks. Colorado Representative Dr. Regina English. Kentucky Representative Donald Douglas.
Present.
Thank you, and hopefully I've got this one right. Louisiana Representative Amy Adado Freeman. New York Assemblyman Ken Blankenbush.
Here.
New York Assemblyman John McDonald.
Here.
Thank you. North Dakota Representative Karen Grindberg. North Dakota Representative Daniel Vollmer.
Here.
Oklahoma Representative Mark Tedford. Wisconsin Representative Barbara Dietrich. right, that's it. And Mr. Chair, we do not have a quorum, so you'll need a motion to waive. I'm sorry, but were there any other legislators I missed? Sorry,
This is
Yes,
State
this
Senator
is,
Justin Boyd.
I got you. I'm sorry, who else was on? I got
This is
Justin Boyd.
South Carolina Representative Carl Anderson.
Oh, sorry, I missed you.
Paula Key from Minnesota.
Thank you. Anyone else?
Okay,
Okay.
I'm here, Anne.
Oh, hi, Brenda.
Hi.
See,
I couldn't
recognize
get
your
this
voice.
computer to work.
I know the feeling.
I do
Great.
too.
All right. Anyone else that I missed here? Great. Well, we still don't have a quorum, Mr. Chair, so.
So we do not have a quorum, so can I get a motion to waive the quorum requirement?
So move, Mississippi.
I'll second from New York.
Thank you and thank you. So we do have the motion and we have the second. All in favor, please say aye to waive the quorum requirement.
Aye.
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 So, thank you all so much. The quorum has been waived, and so good afternoon, happy Friday, as our President Pam Hunter said in her greetings. It's a good afternoon or good morning, depending on where you're at this morning or afternoon. I am Kentucky Representative Sarge Pollock, and I'll be chairing this meeting today. Thank you all for joining. Our purpose today is to conduct some business ahead of the annual meeting in Atlanta this November to ensure that we can address the full agenda there with efficiency and hopefully get some pending matters across the finish line. Today's meeting will focus on two model laws that have generated significant interest so far this year. The NCOIL Prior Authorization Reform Model Act and the Transparency in Dental Benefits Contracting Model Act. Please note that these models will not be voted on today. Instead, this meeting provides an open forum for comments, questions, and discussion, giving us the opportunity to refine our understanding and prepare for hopefully a productive vote in November. So let's get started. We'll start by continuing our discussion of the NCOIL Prior Authorization Reform Model Act. As a reminder, this model language was first introduced during the April meeting, and since then, we've received extensive feedback from interested parties during and after the July session. A revised version of the model was distributed last week, which we can view on the website, along with all other materials for this meeting. Unfortunately, the sponsor of the model, Mississippi Senator Walter Michel, had a last-minute schedule change, so he wasn't able to join us today, but he will be with us in Atlanta in November. However, Senator Michel did ask me to provide some remarks to everyone on his behalf, which he and I have discussed. He apologizes for his schedule change, but he is looking forward to seeing everyone in Atlanta. The revised version of the model that was distributed last week does not represent a final work product. Rather, it represents the next step in the process that hopefully we will be able to finish by November. He is open to making modifications to the model, and indeed the revised version reflects that, but he did ask me to make clear that he was frustrated by some of the comments submitted, particularly on the plan side, that as they were extensive, that if we accepted them when the model, then the model would look nothing like the Mississippi law, which serves as the basis for the model. Senator Michel believes strongly in the Mississippi Foundation, and while hearing everyone's perspectives is obviously an important part of this process, there's only so much to change before the model turns into something else entirely. So with that, he asked me to make clear that between now and November, he will continue to review the comments submitted, as well as the comments made today, and he will make sure further modifications to the model, but what's put forth in November isn't going to stray too far from what was originally introduced. I'm gonna say that was very well said, Mr. Representative Pollock. I mean, Senator Michelle. So with that, let's go ahead and get started hearing from our interested parties. Are there any interested parties with comments or questions on the model? I think we do have one, and a few others, please raise a hand or just chime in when it's convenient. We do have Hope. Are you on the call?
Yes, Chairman Pollock, thank you so much. Appreciate the opportunity to talk with you today and share some of our thoughts from the industry. I'm with Elevance Health, Anthem Blue Cross Blue Shield plans. As you know, the industry has done just a tremendous amount of work in the states and also from a national perspective to simplify, reduce, and streamline prior authorization, including earlier this summer when the industry came together and really elevated our commitment to connect patients more quickly with care and minimize the administrative burden to providers when we released the series of measurable commitments to streamline prior authorization. We really appreciate the process that you all have allowed us to be a part of here. The collaboration on this model is really important, but there are some additional changes that we do hope to see made, and don't feel that they stray too far from the core purpose. As we are a national organization, like many of the folks on the call, we really think that the definitions that are included in here, it's important to align those with some of the federal definitions that are already existing. Also in that note, the turnaround time should really be consistent with those federal requirements that are in the 2024 interoperability and final PA rule. We also think that in this model that's meant to address prior authorization, we shouldn't stray too far from prior authorization, and don't need to blend the claims process, which is really a separate and distinct process from prior auth. Some of the language in Section 12, we believe, does that. And then, as all the folks on the call here, it's essential that we work together with our provider partners in this process. And so while carriers are required to implement the APIs in this, there's no requirement for providers to implement electronic PA or APIs. And with that requirement existing for us, then, we're really being required to build a bridge for nowhere. And so it's essential to have that other connectivity with the providers if we want this to work to its best for our patients and our members. Those are kind of the general overarching issues we see with the existing model, and look forward to discussing more with you and others on the details. Thank you.
Okay. Thank you, Hope. Next on the call, we've got Sandy. Sandy, you're up. Terry, you're on deck.
Thank you. I'm Sandy Gunther, Director of State Government Affairs for the American Association of Oral and Maxillofacial Surgeons. I'd like to thank the committee for their efforts on the model, and I'll keep my comments brief. Oral and maxillofacial surgeons are the surgical branch of dentistry straddling the medical and dental worlds. Due to their unique role, there are some of the few dental providers who regularly bill medical insurance. As noted in our comment letter sent in conjunction with the ADA, we support the provisions of this Model Act, but recommend further additions to ensure our members can be included in the protections offered. All of our members hold a dental degree, but only about half hold a medical degree. We're concerned as currently drafted, those single degree providers who perform the same scope of practice and engage in medical billing just like their colleagues with a medical degree would be unable to qualify for the protections found in this bill. We urge these slight amendments to be inclusive of our membership and to be better positioned down the line as dental and medical care continues to integrate. Thank you for the opportunity to provide these comments, and my contact information is provided in our comment letter if there are any questions after this meeting. Thank you.
Thank you, Sandy. Absolutely. Terry, you're up. Holly, you're on deck.
Thank you so much, Mr. Chairman. I appreciate the opportunity to talk about this fantastic piece of model legislation once again with you. I'll keep my comments extremely brief. I know we have a lot of people in line. I think this bill is fantastic. I really like some of the changes that were made. I just want to speak to a couple of additional changes that I think would support the intent of this legislation and move it towards a place of really impacting even a greater degree of reform in this space. The first is the recent revisions include the pharmacy standard for a standardization process for pharmacy prior auths, but it doesn't include the corresponding medical services prior authorization. As my predecessor from the plan mentioned, there's a federal standard. There's a federal standard that was released in 2024 and specifically involves utilization of the HL7 fire standard. And so I would encourage, just as you included the NCPDP script standard, I would encourage you to include the aforementioned HL7 fire standard in the legislation as well, which would keep the state regulated processes consistent with the reforms that are going to be controlling the federally regulated processes, which leaves providers with a better situation, not having to do two different workflows depending on if the patient has a specifically governed type of plan. The second thing I want to highlight the need for is to encourage that the appeals process, that the review of an actual clinician on denials takes place for all denials and not just on the appeals process. Currently, the process requires a adequately trained physician to review appeals, and that's obviously to ensure that denials of prior authorization are consistent with medical guidelines. However, that would require a patient to have to endure not only a denial and the delays associated with that, but then having to navigate the entire appeals process before they can have an actual trained clinician that would be responsible for ensuring that the denial is actually consistent with medical advice. I would encourage to move that, which is consistent with federal law and other laws in this space, move that to the actual point of denial so that a trained clinician has to review all denials that take place rather than just only those that are appealed by patients and their providers. And the final thing I would point out is I would encourage you to reconsider we had offered a recommendation that this legislation consider all post-acute care prior authorizations to be categorically considered urgent. And this is because of the nature of post-acute care, which is you've got a patient who's already ready to be transitioned when a prior auth takes place. And so any delay, if it takes 7 or so days, is a delay in which a patient's taking up a bed that is not needed for them and is not the optimal place for them to be rehabilitating. So I can speak more on that. And please, I believe you have my contact information. I'm happy to speak more on it. But thank you so much for the opportunity. And I look forward to continuing to work with you all on this fantastic piece of legislation. Thank you.
Thank you, Terry. Holly, you're up. Chad, you're on deck.
Thank you. My name is Holly Brugan. I'm with the American Clinical Laboratory Association. We are the national trade association representing independent clinical laboratories. We want to share our support for the prior authorization reform model bill, while also highlighting some recommendations that will help to better align prior authorization policies with the clinical laboratory workflow. Laboratories are suppliers of services, and prior authorization policies can run counter to the basic workflow of laboratory testing, resulting in denials for medically necessary services already performed. Importantly, for laboratory testing, the date of service is when the specimen is collected, not when the test is run. Thus, in practice, a physician or other clinician typically orders a laboratory test and sends the patient sample such as blood or tissue to the lab with the lab order. By the time the patient sample is collected, the date of service has already occurred, making prior authorization practically impossible. Our recommendations are really focused on aligning prior authorization policies with laboratory order processes in the following ways. One is requiring payers to accept prior authorization requests from laboratories as suppliers of services. Often, providers may not secure prior authorization before they collect that patient sample and submit the test order. So we would really like to see laboratories be explicitly allowed to submit prior authorization requests for the services they perform. Second, we would because of this date of service challenge, we would like to see payers accept prior authorization for clinical laboratory tests either before specimen collection or between specimen collection and the date that a timely claim is submitted to the plan. This helps to account for that workflow issue that I mentioned. And since we don't receive that order until after specimen collection generally, this flexibility would allow labs to secure that necessary information to submit prior authorization for these services before submitting a claim. Finally, laboratories generally only receive the test requisition form, which often includes a number of the necessary components to determine medical necessity. We would really like to see some language included that would require payers to request only medical documentation that is reasonably necessary to evaluate a prior authorization request, including accepting the test requisition form as part of this medical documentation. We have a few other recommendations that we mentioned in our comments, but those three key pieces that are unique to addressing some of the prior authorization challenges with the clinical laboratory workflow is something we'd love to work with any of you on and are happy to discuss at any point. Thank you.
Thank you, Holly. Chad, you're up. Keith, you're on deck.
Thank you, Chairman, and hello to all the legislators. Hi, I'm Chad Olson. I'm with the American Dental Association. I'm here to just emphasize our support for the changes that were recommended by Sandy Gunther from the oral maxillofacial surgeons. I'll just highlight that those changes will show support for the idea that the mouth is part of the body, which is something the ADA very much supports. And it's very important in a situation like an NCOIL model to establish that. And so we support consideration of the term medical and whether it's strategic to and helpful, beneficial to patients and providers for these dental services or oral services to replace that with some either strike it or healthcare. Use that terminology to ensure that the maximum number of people are benefiting from this model. Thank you so much.
Thank you, Chad. Keith, you're up. Emily, you're on deck.
Yeah, thank you, Mr. Chairman. I appreciate the opportunity. This is Keith Lake with AHIP. And certainly I want to start out by saying that we recognize that some of the red lines that we submitted to Senator Michel are perhaps the cause for some of his frustration. But it wasn't our desire and our design to try to go too far astray from the model. In fact, we would argue just the opposite, which is we've all heard Senator Michel say, let's keep the main thing the main thing. So we want to make sure that the model is focused tightly on prior authorization and doesn't stray into other areas beyond prior authorization. We also echo some of the comments that we've heard on here from Elevance and from some of the others as well, that we think it's important that we align the model with the federal laws and regulations so as to have consistency. That will help avoid confusion for not only for the plans, but also for patients and providers. Third, we would echo the comments made by Hope that we focus a little bit more on a two-way street with respect to electronic prior authorization. We need the model to make sure that both plans and providers are moving away from some of the outdated manual submissions, which you've all heard at the meetings earlier this year, are still persistent in the process. And in fact, almost half of submissions today are still being submitted manually. And I think that we need to make sure that we strengthen efforts to require electronic submissions. So we appreciate the fact that the sponsor and NCOIL are open to further edits to the draft. We'll go back and take a look at what we've submitted and consistent with what Senator Michel has asked for, but we would still hope to see some of the additional edits and red lines that we submitted earlier be considered for the next version of this model. And
thank you, Keith. Go
yeah,
ahead.
Chairman Pollock, I would just conclude by saying that if you or the senator if you were to hold an online or an offline work group with some of the stakeholders, we'd be very happy to participate and take the time to kind of dig more deeply into some of these issues.
Okay. Thank you, sir. Appreciate that. Obviously, that is going to be a consideration once me and the senator kind of go over what's being discussed today. Emily, you're up. And I think we've got a Susan, but I'm not really sure if there's a Susan or someone else. I've got your hand up. And so anyway, we'll cross that bridge when we get to your turn. Emily, go ahead.
Great. Thank you so much, Chairman. And I so appreciate being back with you all to discuss this and your hard work on this draft model. We are really appreciative of many of the changes that were made that are associated with the release draft last week. And we appreciate you taking many of our suggestions in the new draft. A couple of things I'll just mention, not to be comprehensive in my suggestions. I think I'll follow up, if it's okay with you, with a letter that outlines a few more detailed suggestions, but really wanted to highlight first concern is still a lack of requirements around the qualification of the reviewer at the initial kind of adverse determination level, rather than putting those qualifications just in the reviewer at the appeal level. We know from data that patients rarely and physicians rarely appeal decisions. And when they do, they're largely overturned. But we just think making sure that there's a qualified physician with experience, expertise, and training at that level is really critical to get it right the first time. Also, in some of the reporting data requirements, we'd really like to make sure the data is as useful as possible, and therefore move away from sort of this aggregated data idea into ensuring that we're seeing data at the claim or the individual service level. I think the more granular we can be in that data, the more policymakers and other stakeholders can use that data to make meaningful reform changes in the future and really understand kind of the black box of prior authorization that kind of physicians and patients sometimes feel there is. So hopefully some of those changes to the data sections can be considered. And then finally, as a couple of folks have mentioned, we really appreciate your focus on standard transaction for drugs, the drug benefit, but we'd really like to see that automation reflected for the medical services portion of the benefits. There are now federal requirements around medical services automation, and we have included some of those suggestions in our previous letters, and we just want to make sure that we're aligned with the federal standards so that the less administrative burden and the easier the process is for patients and physicians when there is alignment. So just wanted to highlight those three. And again, if it's okay with you, we'll plan to follow up with a letter that kind of details all of our continued suggestions. But we really appreciate the progress that has been made and for all your work on this.
Thank you, Emily. Yes, go ahead. There was a little bit of feedback on your conversation. It might be on my end, so a follow-up letter on that might be a little more clear. But I think everyone heard your comments, so appreciate that. Brian, you're up. Go ahead, and then I think Joe, you're on deck.
Thank you very much. And apologies, I know I was looking like Susan for a minute. I don't know what's going on, but it looked like half the people on here are named Susan. So I was able to fix it. So at least I got my name right now. So as it says now, Brian Warren with Biotechnology Innovation Organization, BIO. We had some concerns or thoughts around the response timeline requirements in the bill. And it seems like some of the written comments that have been submitted, people are urging extending those. We would generally align ourselves with the letter submitted by American Medical Association seeking to reduce those timelines. And specifically, I think that we would look at the federal timelines that have been put in place as a floor and not a ceiling. There are some timelines in those that are quite extensive and we fear would put patients at risk. But it does sound like something that perhaps a number of stakeholders on this should continue a discussion on. Because there doesn't seem to be a lot of alignment in terms of different organizations here. But we will follow up in writing as well and look forward to continuing this.
Thank you, Brian. Joe? You're up, sir. And then the unknown Susan, looks like could finish up our last comments. Go ahead, Joe.
Thank you, Mr. Chair. Joe Herdlicka, Senior Manager of Government Affairs at Genentech. We also do not want to stray from the intent of this legislation, but I would echo my colleague Brian Warren's comments. We took a look at this and just want to make sure there's clarity on the timeline elements here, particularly as it relates to emergency services situations. We have a few products in our portfolio where time is of the essence, stroke or heart attack type situations. So that just raised a little bit of concern with us, but we hope we can work with the group to make sure we have clarity on those elements. And thank you for the opportunity to give these comments, Mr. Chair.
Thank you, Joe. Susan, the floor is yours. Are you on the call? Okay, maybe not. The unknown Susan that everybody.
Mr. Chairman, there was someone who had put in the chat that they had requested to make some comments. So there does appear to be some sort of glitch. Susan is she created the Zoom invite in conjunction with Eventbrite. So for some reason, her name is showing up all over this. So I would just say any interested parties can jump right in, Mr. Chair.
Anyone else who has not had an opportunity to comment on this piece, on this model?
Thank you, Mr. Chair. My name is Kara Cheevers, and I'm the Vice President of Coverage Policy at Inseparable. We're a national mental health advocacy organization working to make sure that we are allowing folks to access the mental health care that they need with the insurance that they have. We generally very much support this model legislation and appreciate and celebrate the amount of work that's gone into this language. We've got a few areas of concern or recommendations for improvement. And like the American Medical Association suggested or requested, we'd also like to provide a little bit more nuance in writing after this call if possible. The first area would be really encouraging and recommending that peer reviewers must have current knowledge, expertise, and training in the area of care being provided or being reviewed. And we'd also really encourage that they're able to utilize their training at the top of their licensure or specialization and using the best practice guidelines, regardless of the plan's internal clinical guidelines and medical necessity criteria. We have concern about the automation of medical services. And then in terms of the data reporting requirements, I think this is a really exemplary and positive section of this legislation. Really support annual reporting to the regulating and enforcement agency. We do believe that data should be reviewed and analyzed by service or drug rather than an aggregate. I think that will provide a much more accurate story of these reviews and the percentages of approvals and denials. And when I say percentage, we do support using number rather than percentage because we do believe that tells a clearer story. And on the mental health and substance use disorder side of this conversation, while this data in aggregate is very compelling and will tell an important story, it's incredibly important to bifurcate the reporting requirements to ensure that mental health and substance use disorder services and prescriptions are being reviewed, one, in compliance with mental health parity requirements, and also that the access and potential denials of these services, which are objectively very different than the medical and surgical services, are also being reviewed by those with one, the expertise to do so, and then two, no more restrictively than those physical health services. We also support including the post-service utilization reviews that have been removed. Like I said, thank you so much for the opportunity to review this legislation and provide comments, and we will happily provide more in writing to elaborate on some of these nuances in detail in the future. Thank you very much.
Thank you. Anyone else that has not had a chance to comment on this particular model? If not, I'll open this up to legislators. Are there any questions or comments from our legislators? Lot to take in this Friday. Anyone at all? Okay, thank you for that. Again, I'm hearing consistency federal regs and a lot of those type of stuff. Obviously, a lot of information, a lot of comments. Make sure that obviously you reach out. I look forward to discussing all of this with Senator Michelle and seeing where he wants to take this in advance of our annual meeting. I feel confident that we'll end up in a place where we can get this finished at that time. In the meantime, again, those comments that you've mentioned today, put that in an email to Senator Michelle or the NCOIL staff or myself, so we can really kind of dig back into it. A lot of information, a lot of good information, and obviously we'll continue this conversation. But again, hopefully by our annual meeting in November, we can really get something to where we can put forth a vote. So that's the plan. I do also want to mention before we go to our next segue here, model that as one of the comments was mentioned, I think I shared that in one of our committee meetings in the spring about keeping the main thing. If you guys, I think we're going to maybe print some T-shirts coming up in the annual meeting. If that's something you're looking to do, just shoot an email of your T-shirt size, and we'll make that happen. And so obviously that's been kind of the theme of this whole process this year. President Pam Hunter. Next up is continued discussion on proposed amendments to the NCOIL Transparency in Dental Benefits Contracting Model Act. We've had a productive discussion on this during the summer meetings in Chicago. Since then, I know the interested parties have been actively working with each other and the sponsor to advance specific items. Before we continue, I'd like to turn things over to the sponsor of the amendments and the vice chair of the committee, Arkansas Senator Justin Boyd. Senator Boyd, please go ahead.
Thank you, Mr. Chairman, and thank you to everyone who has worked on this so far and provided input. As you noted, the interested parties have been working on trying to come to an agreement, which I'm encouraged by, but it's my understanding that we're not quite there yet. It's my hope that today's dialogue will serve as a springboard for both sides to continue those conversations, that hopefully we can accomplish what we need to accomplish at our annual meeting in November. I look forward to today's discussion, and I'll turn it back over to you, Mr. Chairman.
Thank you, Senator. Thank you for those comments on this important topic. Assemblyman Gandolfo, co-sponsor of the amendments, would you care to make any remarks?
Yes, please. Thank you, Mr. Chairman. Similar to what Senator Boyd has said, we do appreciate all the work that has gone into this from the interested parties. Going through this process, I've probably learned more about dental insurance than I ever wanted to, but it's been an enlightening experience. And, I know the reason there has been some friction on this is that it is a pretty significant departure from the original model, especially on the network leasing. That said, these laws are not supposed to stay the same forever. There is room to change, and I know both parties will continue to work and try to come to an agreement that satisfies, all the interested parties, hopefully by November. This has been going on for a long time now, but I am encouraged that both parties have stayed at the table and continue to have these discussions. So I'll turn it back over to you, Mr. Chair, and I look forward to hearing some more comments on the matter today.
Thank you, sir. Let's now hear from our interested parties. Any interested parties wishing to speak, please feel free to use the raise hand function or just jump in there and share your comments. Anyone? Okay. We have Bianca. Bianca, floor is yours.
All right, thank you so much, Representative Pollock. We do have a couple of slides we wanted to go through today just to talk through a little bit of background on the model, what it currently offers to consumers and providers, and the amendments that both Senator Boyd and Assemblymember Gandolfo referenced. So I don't know, Ann, if you were planning on pulling those up.
I am working on it. Sorry.
Thank you so much.
I had them all set and they disappeared. Maybe we should ask Susan. We'll see.
But while you work on that, I'm happy to introduce myself. My name is Bianca Bololi. I am the Director of Government Relations for the National Association of Dental Plans. And certainly pleased to present before you all today and discuss the potential amendments that have been referenced. So it looks like.
Nope, that's not it. Let me get it for you. There we go. This should be it. Okay, do you see your first slide?
Yes, we can. Yes, we can see the PowerPoint. It's just not full screen.
Okay, let me get it up to there. A little slow. There, is that working for you?
Looks like we've got a couple boxes, but I can go ahead and kick it off while you continue to work through that whenever.
Sure. This may
Yep,
be
we
as
can
good as
see
it
those.
gets. So.
Okay, that's quite all right. We can go ahead to that first, the next slide. So to start with some context for everyone, the original model was the result of thoughtful negotiations. We believe it balances the needs of consumers, providers, and plans. And the proof of its success is in its adoption rates. In more than 24 situations, we've seen legislators take a look at this model and decide that the model struck the right balances for their state, both in the network leasing and the virtual credit card spaces. The model allows providers choice, it ensures patients have access to robust networks, and it allows plans to build and manage those networks responsibly. Go ahead to the next slide, please. A few things on what the offer as it's written currently offers. For consumers, more robust networks with a wider pool of participating dentists. It also offers lower in-network cost, which directly translates to savings at the dentist office, which is significant. Additionally, it offers predictability around out-of-pocket expenses, something we know patients deeply value when making their healthcare decisions. More provider options so families aren't forced to switch dentists when coverage changes, and clear quality standards that ensure patient protection and access to quality dental care. For providers, the opt-out system is empowering. They aren't locked into a take it or leave it arrangement. They receive notices for networks when their network is leased, and they know what payment options are available to them. And critically, they have the ability to walk away if the arrangement doesn't provide value or suit their needs. From an administrative standpoint, building a network is like building a bridge. It takes time, investment, and coordination. An opt-in requirement would force plans to rebuild those bridges. That creates confusion for providers and would result in weaker networks for consumers, making the entire system less efficient. Next slide, please. As noted by Assemblymember Gandolfo, the amendments that have been proposed are a significant change from what is currently in the model, a drastic departure from what currently stands. It is a fundamental shift, moving from an opt-out to an opt-in. While it might sound like a technical change, in practice, it does flip the entire framework upside down. There isn't a strong policy justification for rewriting the model. Providers of all sizes join networks because they see value, greater patient volumes, predictable reimbursement, and administrative efficiencies. That's true whether they're part of a large dental group or a solo practice. Networks, including lease networks, are carefully constructed. Lease networks specifically help smaller carriers compete with larger players. For example, a regional dental plan may not have the resources to build a nationwide network, but through the process of leasing, it can give its members access to care across state lines. That creates competition and additional choice in the market, and ultimately more competitive pricing for consumers. In short, what looks like a technical policy tweak represents a major shift in practice and operations. It places a significantly heavier burden on providers who want to expand plan options or elect a payment method best suited for their practice. Perfect, thank you, Anne. We believe that there are opportunities to improve the model without upending the framework. And what we did was draft some amendments that we believe would do just that. That doesn't mean that the substantial change is a massive change is needed, but instead just simple tweaks that could improve this for plans, patients, as well as providers. Therefore, we've proposed the following updates. Within the network leasing section, we are proposing an affiliate definition, which clarifies language to ensure everyone, providers, plans, and regulators know exactly how leasing applies. This would reduce confusion and build trust in the process. Additionally, we have added an additional notice, which would occur following the execution of a lease, giving providers more time and information, both before the lease takes place, which is currently in the model, and then following the lease's execution, in order to make better business decision and to increase transparency. And then in reference to electronic payments and virtual credit cards, we are proposing future-proofing payment options. This is something that was proposed in the opt-in amendments that have been proposed by our counterparts. Specifically ensuring that as technology and payment methods evolve, that the model remains effective and allows for the opt-out to apply broadly. We have also added alignment with existing federal requirements to provide further protections for providers related to electronic payments. And finally, also as included in my colleagues' amendments, the sticky opt-out choices, as what we're referring to it as. So once a provider opts out, that decision stays in place until they choose otherwise, or for the duration of the contract, in order to save time and avoid any unnecessary back and forth. We believe these are common sense updates that make the model stronger, more transparent, and more future ready, all without tearing apart what we know is already working. So with that, I do appreciate the time to present before you. We believe the model as is with these changes empower providers, protects consumers, and ensures competition in the market. Excuse me. I would be happy to take any questions. My contact information is included if anyone would like to reach out directly.
Thank you, Bianca. Appreciate those comments. Chad?
Yes,
You're
so
up.
thank you, Chairman, and appreciate the time and the ability to speak to the comments made by the National Association of Dental Plans, and also just to talk through the ADA's perspective. There was a lot of loaded language used in the last presentation, things like words like drastic, et cetera. I have to say, as a representative of the dentists around the country, I always find it amusing when dental plans choose to speak for providers. And you heard that happen a number of times. I would just refer the legislators on the committee to the letter that was submitted a few days ago from not just the American Dental Association, but a whole host of provider dental oral health organizations that all commented in support of the amendments as they were drafted and submitted by Senator Boyd and Assemblyman Gandolfo. But I'd like to talk a little bit about opt-in, and as Bianca spent much of her time speaking about opt-in and how this would be a drastic change, I think it's important for the committee to understand a couple of things that we've covered in the past. NADP's comments were very similar to what you all have heard, so I'm going to do a little repeating of things that you've heard. Opt-in is a solid policy choice. It is something that empowers both patients and providers. On the provider side, you all know that you receive emails or communications, and if you are forced to opt out of something, you often end up signed up for something that is not appropriate or not something you're interested in. This is a very critical issue for the small businesses. Largely, that's what dental offices are still around the country. The small businesses around the country where it is can be a huge financial burden to be forced into something and then have to opt out later. I know it's convenient for the plans to build their networks in the manner that they have been doing, and it has spread like wildfire around the country to lease networks. I would push back on the comments that these are carefully considered. I think that in the past, dental plans built networks in as Bianca alluded to, in a way that was considered, and there was connections made with providers in the plans. That is no longer the case. It is a patchwork, and it is trying to enter into spaces without a relationship, and who's left holding the bag? It's the providers. I would also point to the confusion that occurs for patients. Bianca alluded to lower fees that the patients may be paying. I will tell you that being in and out of a network based on whether you're jumped in or out is also confusing for patients. I can detail again examples where providers have had to, they found out that they've been jumped into a network, and then they have to work with their patients to tell them why they're no longer in the network, and it causes confusion all around. Again, an example of dental plans interference getting between the doctor and patient relationship. So I'd like to next, I know I'm taking a little bit of time, but I think it's necessary. I'd like to just jump through the amendments that's proposed by NADP. Again, they do not address the opt-in and do not build on the original amendments that we set forth, except for virtual credit card, and I'll get to that in a second. With regard to the definition, the industry definition of affiliate is unnecessary and does not adequately address the issue that entities that do not share a brand are claiming affiliate status around the country. The original Boyd-Gandolfo amendment that better addresses this issue by clarifying that brand status needs to be transparent for providers to access. On the issue of leasing, and again, that's where they spent the bulk of the time, this is not a drastic change. It is also, I think, I wouldn't characterize it as something that's just a tweak. We know that this is a shift, but it is a necessary one, and as I said, will be helpful to both providers, and I remind you, all providers support this, and it also is helpful to patients to keep things transparent. We support the plans being able to build networks, but we think they should do it in a way that is better based on connection with provider. Now, as Bianca alluded to, we are closer on virtual credit card, but again, they have avoided opt-in and the issue of explicit acceptance. We would ask that the legislators on the call support this. These are critical for providers to make good choices. Additionally, we are pleased to see that the industry sees the wisdom of permanent selection of the virtual credit card or some other form of payment. But again, we feel our language is superior. But this is the closest that we came to accepting some of our language. Again, I would just emphasize for all the legislators on the call that this is an issue that, as Assemblyman Gandolfo said, he's known more about dental insurance than he ever wanted to. That is also something that is true for the dentists and patients out there that want to get the care they need when they need it and want to understand what the coverage is as much as possible. The amendments as originally drafted reflect that, and we urge you to support them. I'm happy to take questions now or in the future and work with the interested parties. Thank you so much for the time, Chairman and legislators.
Thank you, Chad. Owen, you're up, and Jeffrey, you're on deck. Please go ahead.
Yeah, thank you, Chair Pollock, and good afternoon, everyone. My name is Owen Urich. I'm with AHIP, America's Health Insurance Plans. Just wanted to briefly echo the comments from my colleague at NADP, Bianca. We're supportive of the industry's proposed alternative amendments. Really, I think in trying to do a couple of things. One is build on the success of the existing model. You know, as Bianca mentioned, this has been adopted in over a dozen states. This is a method. This is where, you know, carriers have developed practices that have been proven effective. But I do want to note on the side of our proposed amendments that, you know, we are trying to address concerns that have been raised on this, you know, without upending the apple cart, and also making sure that this is as transparent and clear as possible without making significant changes that could cause issues. So, you know, again, reiterating that the opt-out method as it is currently included in the model would be preserved in our amendments. But in addition to that, you are also going to be giving additional notices. You know, we're making sure that this is clear as and upfront as possible. You know, I certainly welcome a dialogue, you know, with Chad and with others about education and other things that would be important for our members, but also for, you know, the broader community to discuss about information related to this. But we want to make this process as clear and as straightforward as possible. I think that's the unified goal, both on leasing and on the electronic payments section. Again, that's why, in the amendments that were proposed by the industry, that we were pointing to federal standards as it relates to, electronic payments. It's something that we want to make sure that, that option is available for ACH, and that also, I think it's a shared goal to make sure that there's more speed and efficiency and transparency in payments that's shared across the board. And I think that we're trying to achieve that with our proposed amendments. And again, building off of the success of the model with those. So, appreciate the time. Just wanted to reiterate our support for statements by NADP and welcome the further dialogue. Thank you.
Thanks, Owen. Jeffrey, you're up.
Thank you, Mr. Chairman. I represent, most of you know me, I do work for the American Bankers Association Health Savings Account Council and their Office of Insurance. But in this instance, some folks on the bank side who are involved in the virtual credit card area asked me to weigh in support of Bianca and NADP's position in view of the fact with respect to virtual payments that we have 11 states that have the existing model language. The system seems to be working. We don't want to do anything in the way of overregulation in constricting the way virtual credit cards can be made available. Of course, like everybody else on this call, we use Dennis. We support transparency and understand the goals associated with that. So the ABA started tracking this issue way back when you had your meeting in Chicago, and I got in Charlotte, and I got re-engaged with NCOIL right before the pandemic. But after the July meeting in Chicago, they asked me to go on record in support of the NADP and AHIP. And thank you for your time and comments. I won't belabor the point.
Thank you so much. Jill, you're up.
Thank you, Mr. Chair. I am Jill Rickard with the American Council of Life Insurers. And as many of you know, many of our members do write dental insurance for the smaller dental plans. I just wanted to weigh in again in support of NADP as well as AHIP, and the position that the model should be readopted as is or adopted with the amendments proposed by NADP. The proposed ADA amendments would change in a really major way how the dental market operates, and importantly cause significant disruption for patients who benefit from networks and the existing opt-out process for network leasing. ACLI and its member companies are committed to transparency, and the amendments we feel proposed by NADP would enhance that transparency without disrupting the market. That's all I have to say, so thanks for your time.
Thank you, Jill. Walter, looks like you may be our last one. Go ahead, sir.
All right. Thank you, Mr. Chairman. Hey, this question would be directed towards Chad, possibly at the American Dental Association. Jeffrey Klein had mentioned that 11 states currently are on the virtual credit card option. And I guess my question to you is, how many states have implemented an opt-in approach to the network leasing?
Yeah, thank you. Thank you for the question. Yes, we've seen one state, and it's again reacting to the difficulties that providers and patients are seeing. Oregon has adopted virtual credit card with an opt-in, and that was a recent adoption. So we're seeing that this policy choice is starting to shift. Thank you for the question.
Thank you, Mr. Chairman. Thank you for your answer. Your answer was one, is that correct?
Yes, one so far, but we're also seeing introductions of bills that include opt-in. So
what state would that be?
I can get that answer for you in just a minute if you give me a chance to research. But
that's fine. That's fine.
Yeah.
Thank you. Appreciate it.
Anyone else who's not commented at this point? I am trying to get me a little power going on here. Sorry for the. Anyone else? I'll now open this to our legislators. There's been a lot of comments, obviously a lot of discussion. So legislators, the call is yours. Anyone would like to comment?
Sarge, this is Brenda.
Hey, good morning. Go ahead.
Okay, I guess this is a comment. I reached out to LIAM here in Michigan, and we're going to go review the model legislation. I'll have more feedback for you probably before the annual.
I'm sure you're not the only one on that. Definitely will do that. That's for sure. Thank you, though. Anyone else? Any other legislators? Okay. Senator Boyd, care to have any closing remarks?
Just like to say thank you for all the comments today. I'll take them into consideration as we move forward. But I hope that we can find some resolution and closure to this at the annual meeting. Thank you.
Thank you. Assemblyman Gandolfo, any closing remarks?
Ditto.
Well, definitely we've had a lot of conversation on this, and before we wrap it up, I would just like to offer my perspective on this as the chair, particularly on the network leasing issue. I agree with some of the comments that have been made today regarding making sure that we're all clear about the amendments to the model. We've been discussing it for a while now, and the more I've heard and listened to, the more drastic these amendments seem to be, and they really would represent a significant policy shift from the original model. I know it's our job as policymakers to listen to the concerns of constituents and of the industries, and we oversee and then respond appropriately with legislation. But I'm not quite sure I've heard enough justification to make sure a significant change to the NCOIL model. Perhaps this might be an issue that's better left to the states that wish to take it up. Also, from the NCOIL procedure perspective, I think it's great and proper that our models come up for review every 5 years. But I would say that at the first review that is this 5 years after initial adoption, any changes to the model should be reserved for clarifications or perhaps changing something that is outdated or maybe responding to a policy shift in the states. This change seems a lot more substantive in nature and is not something that a lot of states have done. Again, it kind of goes back to the comment of obviously possibly keeping the main thing. But overall, this has been a great discussion, and this is what NCOIL is all about. I look forward to meeting again in November, working with Senator Boyd, Assemblyman Gandolfo to finalize everything. In the meantime, if you have any questions or you would like to share feedback, please feel free to reach out to me, again, the NCOIL staff or Senator and the Assemblyman. Is there any other business that anyone would like to raise? I'd just like to remind everyone about registration for the annual meeting in Atlanta. Please be sure to register and book your hotel as soon as you can. Obviously, we've got a full agenda coming up in Atlanta. We'll be having our 4th annual golf outing to benefit the ILF Scholarship Fund. Registration for that is open as well. Please be sure to register for now to reserve your spot. Hearing no further business, I'll entertain a motion to adjourn and then a second.
I move.
Thank you. Do I have a second?
Second.
Thank you so much. Ladies and gentlemen, have a happy Friday, great weekend, and we'll see you in Atlanta.
Great to see you.
Thank you all.